Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I'm pleased to welcome you all to the final live session of the day titled Understanding Targeted Therapies for Lymphoma and CLL. As mentioned previously, this Zoom software does not allow you to access video features or turn on your microphone. At the end of the presentation, we'll try and leave a few minutes for questions. And in order to do so, you can type them in the questions box, which is in the middle of the black toolbar at the bottom of your screen. So without further ado, joining us today is Dr. David McDonald, who is a hematologist at the Ottawa Hospital and assistant professor in the Department of Medicine at the University of Ottawa. He received his MD at Queen's University and did residencies in internal medicine and hematology at Dalhousie University. He then did a clinical trials fellowship at the National Cancer Institute of Canada Clinical Trials Group, then a clinical lymphoma fellowship at the BC Cancer Agency in Vancouver. He was the chair of the Hematology Cancer Site Team for Cancer Care Nova Scotia for 10 years before moving to Ottawa in 2017. He is a member of the Scientific Advisory Board at Lymphoma Canada, and his clinical and research interests are clinical trials of novel therapies in lymphoma and CLL. So thank you, Dr. McDonald, for joining us today, and you can get started as soon as you're ready.
Okay, great. Thanks, Gurjit, for that introduction. Very happy to be here. I hear that there are several hundred people online, so that's really a fantastic turnout, and hopefully we'll learn something together today. So I was asked to talk about targeted therapies in lymphoma and CLL, and I think that targeted therapies is a bit of a buzzword, so it's a good opportunity to discuss what we mean by that, and to really talk about what we really mean, and that is a movement towards chemotherapy-free or chemo-free treatment regimens. So I've divided the talk into three sections, and the first section, I'll talk about sort of a definition of what is a targeted therapy. And again, the goal is to move towards a chemo-free future. So how do we define chemotherapy? Well, as you know, human cells divide. They divide at a regular pace, and cell division in the human body is a controlled thing. So we don't want cells dividing out of control. We want them to divide when it's necessary to reproduce and regenerate. And we want them to pass away and die when they've reached the end of their lifespan. So all of that is controlled through normal mechanisms. Now, cancer cells also divide, and unfortunately, cancer cells divide faster than normal cells do. And so that's why cancer tumors grow faster than normal tissue, but it does give us an opportunity to attack cancer tissues with conventional chemotherapy. So conventional chemotherapy is medication that targets the cells that are in the process of dividing. And there's several stages in the cell cycle where different chemotherapy agents may have their action. But the overall purpose of the chemotherapy is to prevent division and growth of the cell, and therefore the clone of cancer cells will eventually die out. Unfortunately, though, chemotherapy, while it primarily affects cancer cells, it also affects any other cell that's dividing. And there are some cells in the body that naturally divide at a more rapid rate. Those would be cells involved in organs where there's lots of cell turnover because there's normal damage or normal wear and tear. So in the skin, in the hair, in the lining of the intestines, those are places where we have human cells that do grow at a more rapid rate. And unfortunately, that means that those particular areas are susceptible to the side effects of chemotherapy. Similarly, our blood cells, fortunately, our blood cells are rapidly dividing so that we can constantly replenish our blood supply. But chemotherapy has an effect on our normal blood cells and causes low blood counts like anemia, thrombocytopenia, and neutropenia, which can lead to infection. So these are some conventional chemotherapy regimens that you might have heard of. On the left, we have CHOP, which is, has been our standard treatment for diffuse large B-cell lymphoma for many years. At the top, we have ABVD, standard therapy for Hodgkin lymphoma. Towards the right, we have fludarabine and cyclophosphamide, or FC, and that's been our standard chemotherapy regimen for CLL for a long time. And at the bottom, we have bendamustine, which is more useful in indolent lymphomas, but also in CLL. So those are conventional chemotherapy regimens that you might have heard of. Now, if you add a monoclonal antibody to that, so in each one of those, if you add rituximab, you get R-CHOP, FCR, and BR, for example. We refer to that as chemoimmunotherapy. So chemoimmunotherapy would be conventional chemotherapy with the addition of a monoclonal antibody like rituximab. And I'll talk about chemotherapy, I'll talk about chemoimmunotherapy as we go along. So this sets the stage. Now, this is just a graphic to show what I've already said. That is chemotherapy. You can think of it like a bomb, right? The bomb gets dropped into the field, and in that field, we have cancer cells, we have normal blood cells, we have skin cells, hair follicles, we have cells that line the intestine. And unfortunately, the bomb doesn't know or care which cell is dividing. So it really just, it blows everything up. And that's why it's effective against the cancer cells, but it also has the side effects when it affects the normal cells. So have that image in your mind of chemotherapy as a bomb. So then how do we define targeted therapy? Well, there are these pathways that occur inside of the cell, and those pathways are essentially a series of proteins that pass a signal from the surface of the cell down to the cell nucleus or to the mitochondrion or whatever. But those pathways are responsible for turning things on and turning things off. So for example, if you have an infection and you need to turn on production of antibodies, there are biochemical pathways within your lymphocytes that are designed to do that. If you injure your skin, if you burn your skin, for example, and you need to heal and create new skin, there are pathways within the skin cells that enable the skin to turn on production so that it can heal that faster than it would otherwise. So pathways turn on or turn off cell division, but they also can turn on and off cell death within the cell. So what we know is that mutations that occur inside cancer cells can cause overexpression of these certain pathways, certain proteins within the pathways. And if we can identify a protein that is overexpressed in a cancer cell, and if we can develop a medication that targets that protein, then that pathway which is turned on, which leads to proliferation of that cancer cell, can then be turned off with the targeted therapy. So that's what targeted therapy is. It's therapy targeted to these proteins that are overexpressed within cancer cells. I teach lymphoma biology to medical students and residents, and I like to teach them about this very concept of mutations that occur in specific lymphomas that help us to understand why those lymphomas occur. So for example, in follicular lymphoma, which is our prototype of indolent B-cell non-Hodgkin lymphoma. So it's a non-Hodgkin lymphoma, it's indolent, which means that it's slow growing. And what we know is that if we test cells from somebody who has follicular lymphoma, we find that there's a mutation that's occurred in their lymphoma cells that causes overproduction of this protein that's called BCL2. BCL actually stands for B-cell lymphoma. So the protein's named after the lymphoma, BCL2. And BCL2 is actually present in all of our cells. It's a normal protein that's in our cells. And the role of BCL2 normally is to inhibit the cell from dying. In other words, you have a cell, a normal cell, and it has a normal lifespan, and you want to protect that cell from dying early. So BCL2 is a pathway that turns off or inhibits the cell from dying. Now, what happens though if you overproduce BCL2? So in follicular lymphoma, we're overproducing BCL2. We have way too much of it. And what that results in is it prevents that cell from ever dying. So that lymphoma cell will then live much longer than a normal B cell. And therefore, if it's living longer, but they're reproducing at the same rate, then gradually over time, you get the formation of a tumor. And that's why follicular lymphoma is considered an indolent lymphoma, because there's slow growth. It's not like it's proliferating rapidly or rapidly reproducing. The contrary, it's not dying when it's supposed to die. So gradually over time, you get accumulation. So that's BCL2 and its responsibility for causing follicular lymphoma. Now, if we take the opposite end of the spectrum and look at Burkitt lymphoma is one of the most aggressive types of B-cell non-Hodgkin lymphomas. And in Burkitt lymphoma, the specific mutation that occurs causes overproduction of a different protein, and the protein is called c-Myc. And the role of c-Myc in normal cells is to turn on cell division or to drive proliferation of the cell. So once again, c-Myc is a normal protein, it's present in our normal B cells, but it gets turned on in Burkitt lymphoma cells so that it's overproduced. And now what you have is this constant stimulation of reproduction And so those cells are rapidly dividing, and the consequence of that is a highly aggressive lymphoma. You have a tumor that can grow from non-detectable to 5 or 6 centimeters within a week or two. That's how aggressive that is. So if you can understand those two mechanisms, you can understand why we can now identify many other proteins that are overexpressed in different lymphomas and in CLL that we can then target so that we can turn off or take away their drive to cause those cancer cells to have an advantage. So on the left is really quite a complicated diagram that looks at many of the different pathways that are involved in the B cell, in the normal B cell, but also that are activated or upregulated in patients with diffuse large B cell lymphoma. And so I don't know how large this is on your screen, but it doesn't matter if you can see the words. I'll just point them out. So you've got BTK. So we have inhibitors of BTK. You have BCL2 protein down here. We have inhibitors of BCL2. There's PI3K. We have an inhibitor for that. There's SYK. We have an inhibitor for SYK. We have AKT inhibitors. We have mTOR inhibitors. We have BCL10 inhibitors, MALT1 inhibitors. Really, all of these different proteins are potential targets. And if they're upregulated in cancer cells, and if we can develop a drug that will turn them off or prevent them from working, then that's what a targeted medication is. So again, some of the proteins can be targeted by medications that can get inside the cancer cell. They can block those proteins from driving the pathway forward and therefore turn things off and cause that cell not to reproduce fast or not to become, resistant to dying. So if you remember the metaphor of chemotherapy as the bombs, well, then targeted therapy would be the guided missiles. So these guided missiles are targeted at pathways that are upregulated within cancer cells. So they're going to have much less effect on normal cells where the pathways are not activated. So then we can take this concept one step further, and we can say targeted therapies can lead to personalized medicine. So what do I mean by that? Well, we know that no two diffuse large B-cell lymphoma specimens are the same. So diffuse large B-cell lymphoma in one individual may express one panel of proteins, and in another individual, it may express a different panel of proteins. And about 20 years ago, there was a study done that looked at hundreds of patients with diffuse large B-cell lymphoma, and it dissected out their lymphoma cells, and it did a study looking at proteins that were expressed within those cells. And what they found was that they could divide diffuse large B-cell lymphoma, previously thought of as one disease, but they could look at patterns and divide those hundreds of samples from diffuse large B-cell lymphoma into two different groups. And in one group, a certain set of proteins was overexpressed, and in the other group, a different set of proteins was overexpressed. And so those groups have become known as either the activated B-cell type or the germinal center B-cell type. So we have ABC, diffuse large B-cell lymphoma, and we have GCB, diffuse large B-cell lymphoma. Under the microscope, they look the same. They look like diffuse large B-cell lymphoma, but if you can do these molecular tests and see what proteins are expressed, you can divide them into the two different groups. Now, not only can you do that, but that study was able to identify several of the specific proteins that were overexpressed. So for example, NF-kappa B is overexpressed in the activated B cell type, but it's underexpressed in the germinal center B cell type. So if you have a drug that targets NF-kappa B, then obviously it would make sense to use that drug in a patient who has activated B cell diffuse large B cell lymphoma, but it's not likely to be very effective in a patient that has germinal center B cell diffuse large B cell lymphoma. And so that's what I'm talking about, personalized medicine. So if we can take a specific patient's tumor and we can identify what proteins are expressed, then we can give them specific medications that would work in them, but wouldn't necessarily work in other patients with the same type of lymphoma. So that's the definition of targeted therapy. So now in this second section, I'm going to talk about three particular important targeted therapies that really have made a name for themselves in lymphoma and CLL. These are probably the three most important targeted therapies that we can talk about, but they're only 3 out of dozens and dozens of targeted therapies that have been developed, both in CLL and in lymphoma. So I'm going to start with BTK inhibitors, which many of you have probably heard of. So BTK stands for Bruton's tyrosine kinase. And again, BTK is present in normal cells, and its job in normal cells is to control proliferation and survival of the cell. So if you need that cell to proliferate in order to heal damage or to respond to infection, etc., then the BTK will be turned on and that cell will become proliferative. If you no longer need that, then the BTK will turn off and the cell will go back to sort of a resting state. But what we find is that BTK protein is overexpressed definitely in CLL and in many of the lymphomas as well. And so BTK inhibitors are targeted therapies that block the BTK and turn off the proliferation and survival pathways. So again, if you have a CLL clone of cells, and in that CLL clone of cells, you have overexpression of BTK, and it's the overexpression of BTK that's driving the proliferation of those cells. If you can turn off BTK in those cells, then you can turn off the process and put the CLL into remission. So that's the theory of BTK inhibitors. Now, it turns out that it's not just a theory, it's a theory that in practice has been effective. So we now know that BTK inhibitors work better than chemotherapy in CLL. So there are many trials looking at different types of BTK inhibitors. This one was ibrutinib, which was the first BTK inhibitor on the market. This was called the FLAIR trial, and it was a randomized study where some patients received ibrutinib and other patients received FCR chemotherapy, which was the standard at the time. You can see it's a relatively large study, so 263 patients on both arms, over 500 patients altogether. And if you look at the results of this study, if we sort of drop down to the bottom, the overall response rate with the ibrutinib was almost 95%, whereas with the FCR chemotherapy, the overall response rate was only 84%. I mean, 84% is great, but 95% obviously is better. If we now go to the top line, we can say, well, what is the progression-free survival? So that's the likelihood that somebody is still going to be in remission without a progression by the 5-year mark. With ibrutinib, it was 80%. With FCR, it was only 62%. So almost a 20% improvement in the likelihood of a remission lasting for 5 years. And perhaps most importantly, what about the likelihood of being alive in 5 years? So if a patient was treated with FCR, their chance of being alive at 5 years was 88%. With ibrutinib, it was 91%. So even the overall survival was improved. Now, this next line actually is an interesting line, and it kind of goes against what I've been saying. So if you look at MRD refers to minimal residual disease. So if you could take a patient who had CLL and you could use the most sensitive and sophisticated test that you could imagine to find every last single cancer cell in that patient. If you can find one, then they have residual disease. If you can't find one, then they have undetectable residual disease. So undetectable minimal residual disease. So very interesting. The undetectable minimal residual disease rate was actually 60% with chemotherapy with FCR, and it was 0% with ibrutinib. So even though ibrutinib had better response rates, better length of remission, better chance of overall survival, the response in patients who received FCR was actually a deeper response. There was undetectable disease in a far greater number of patients that had FCR, and that kind of is counterintuitive. So this concept of minimal residual disease that you'll hear about when we talk about CLL and certain lymphomas, it's important, but it doesn't necessarily predict how good the treatment is in the big picture. So that was the clinical trial of ibrutinib versus FCR in CLL, showing that ibrutinib was better. There are other places in non-Hodgkin lymphomas where we have access to BTK inhibitors. So we have BTK inhibitors that are approved for relapsed mantle cell lymphoma, relapsed Waldenström's or lymphoplasmacytic lymphoma, and in relapsed marginal zone lymphoma. So we do have BTK inhibitors available for patients that have these relapsed lymphomas. And very interestingly, now we're starting to combine BTK inhibitors with chemotherapy. For example, in patients with previously untreated mantle cell lymphoma, and I'll show that in a second. And in other trials, so in diffuse large B-cell lymphoma, we did a clinical trial adding acalabrutinib to R-CHOP compared to R-CHOP alone. That trial finished recruiting a few years ago now, and any time now we'll start to see the results, and we'll find out if you add a BTK inhibitor to R-CHOP in diffuse large B-cell lymphoma, can you improve the cure rate? In Canada, we've done this study in Waldenstrom's called the BROM study, where we've added acalabrutinib to BR. So BR, bendamustine rituximab, is the standard chemotherapy in Waldenstrom's. And in the BROM study, we added acalabrutinib, and we'll be seeing final results of that study very soon. And I think people will be very impressed with that. So I mentioned combining BTK inhibitors with chemotherapy, and what we've seen that in mantle cell lymphoma, that approach actually is better than chemotherapy alone. So this study was called the Triangle study. It was done in patients with mantle cell lymphoma who were relatively young, relatively physically fit, and therefore were eligible to receive an autologous stem cell transplant. You have to have some youth and some fitness to be able to withstand that. And there were 3 arms of this study. The first arm was arm A, and in that arm, standard chemoimmunotherapy followed by autologous stem cell transplant was the treatment. That is considered, or was considered at the time, our standard way of treating younger patients with mantle cell lymphoma. The second arm took that very same treatment, and it added ibrutinib both during the chemotherapy and excuse me, after the stem cell transplant. So testing whether if you add a BTK inhibitor to your standard therapy, does it make the outcomes even better? And then the third arm, which was even more bold at the time, was saying, okay, well, if we add ibrutinib to the chemoimmunotherapy and remove the stem cell transplant, can we still do just as well? Can we avoid all the toxicity of that stem cell transplant, which, if you know anything about transplant, it's essentially extremely high doses of chemotherapy. So if we can get away without it by adding the BTK inhibitor, then that's even better. So if you look now at the results of this study, the Triangle study, so the 3-year failure-free survival. So failure-free survival means patients were still alive, in remission, had not relapsed, and had not died. So at 3 years, with the standard treatment, 72% of patients were in that failure-free survival. If you flip that on its head and say 28% of patients had failed their therapy by the 3-year mark with the standard therapy. When you added ibrutinib, that 72% goes up to 88%, or the 28% who had failed, that goes down to only 12% who had failed therapy by the 3-year mark. And if you remove the stem cell transplant, that 88% doesn't go back down to 72 or lower. It only goes down by a tiny notch, down to 86%. So in terms of failure-free survival, adding ibrutinib to the standard chemotherapy was better than standard chemotherapy alone. And adding the ibrutinib to the chemotherapy and removing the stem cell transplant was about as good as if you gave the stem cell transplant. So 2 conclusions from that. 1, adding ibrutinib to frontline chemotherapy is a good thing. And 2, we no longer need to do stem cell transplants in these patients. Similar if you look at the 3-year overall survival, so the chance of being alive at 3 years, 86% with the standard, 91% if you added the ibrutinib, 92% in this other arm that added ibrutinib. If you look at complete response rate, it was higher, 45% with ibrutinib compared to 36% without. And if you look at the overall response rate, it was 98% with ibrutinib and 94% without. So definitely BTK inhibitors plus chemotherapy are better than chemotherapy alone in mantle cell lymphoma. So ibrutinib was the first BTK inhibitor that came along. The second one was acalabrutinib, and the third one was zanubrutinib. Those are all now considered to be what we call covalent non-reversible BTK inhibitors. When we use them, we intend them to be continuous therapy. In other words, you start on one of these medications, and it's intended to continue for as long as it's working, and you're not having significant side effects. So I have patients who have been on ibrutinib for CLL now for 10 years, patients on acalabrutinib for 5 years, and zanubrutinib now for 3 or 4 years. They're still in remission, they're still on their therapy, they're not having significant side effects, and so we keep on going. But the problem is that resistance can develop over time. And so if you've been on one of these BTK inhibitors and you've been in remission for 4 years, and now suddenly you're starting to lose that remission, then the chances are the binding site where the targeted therapy fits into the BTK may have undergone a mutation so that the BTK inhibitor no longer fits. So if you want to think of the medication acalabrutinib as a key and the BTK as a lock, as long as that key fits in the lock, it'll work. But if there's a mutation that occurs that changes the shape of the lock, then that key can no longer fit in that lock, and therefore resistance develops and it no longer works. But fortunately, we have now pirtobrutinib and nemtabrutinib. These have come along and they're different. They're non-covalent, reversible BTK inhibitors. And so now, instead of these keys fitting inside the lock and locking in a non-reversible way, they come in, they touch the surface of the lock, and then they go away, and then they come back, touch the surface of the lock again, and then they go away. They keep doing this. They don't have a covalent bond. They don't get stuck into the lock, but they keep coming and touching the lock in a reversible kind of way. And now, if the lock has mutated, it doesn't matter anymore because that key doesn't need to fit inside it. It just needs to touch it on the surface. And so that's how I think of pirtobrutinib as working. Now, where are these drugs? Pirtobrutinib is available on a special access program. It's approved by the FDA in the United States. It can be brought into Canada in very special circumstances, but very soon I expect pirtobrutinib to be more widely available in Canada. Nemtabrutinib is still in the final phases of clinical trials. We have a clinical trial of nemtabrutinib here in Ottawa and other places in Canada that trial is running. So these are ibrutinib, acalabrutinib, and zanubrutinib are on the market now. Pirtobrutinib and nemtabrutinib are soon going to be available. So even for patients with CLL who are currently on these BTK inhibitors, if those BTK inhibitors, acalabrutinib and zanubrutinib, stop working, by the time that happens, it's likely that these other medications will be available to them. So moving to the second class of targeted therapy, I'm going to talk about BCL2 inhibitors, also a very important class. So I've already talked about BCL2 when I told you that it's the protein that gets mutated in patients with follicular lymphoma. So it's a protein that regulates apoptosis or cell death. So you want to have some BCL2 so that your cells will die when they need to, but you don't want to have overexpression of BCL2 because it will make the cells live forever and therefore they'll accumulate over time and they'll form these tumors. So BCL2 is overexpressed in CLL and in various lymphomas, including follicular lymphoma, which I already talked about. So if you have overexpression of BCL2 and you can inhibit that by targeting that with a BCL2 inhibitor, then you can effectively block that BCL2 and you can turn back on the ability of that cell to undergo apoptosis and to die a natural death, which again is what you need. It doesn't sound right, but it's what you need. So venetoclax is the first available BCL2 inhibitor. I'm sure that there are people online who have heard of venetoclax, probably many that are on venetoclax. The first approved use of venetoclax was as a monotherapy, that's therapy by itself, in patients with relapsed CLL. Sorry, I'm in my office and my overhead light seems to have timed out, so I'm just going to talk in the dark. Oh, that's okay. Venetoclax is now approved in combination with rituximab for people with relapsed CLL or in combination with obinutuzumab for people with previously untreated CLL. I mentioned rituximab before. That's a monoclonal antibody, so it's still a targeted therapy. It's still chemo-free to give rituximab along with venetoclax. Obinutuzumab is a newer generation anti-CD20 monoclonal antibody. So these are still chemo-free regimens. So where I talked about ibrutinib, acalabrutinib, zanubrutinib, they're continuous therapy. You use them for as long as they're working or until progression of the disease. Venetoclax is time-limited therapy. So when you get venetoclax with rituximab, the duration is for 2 years. And when you get venetoclax with obinutuzumab, it's for 1 year. So time-limited therapy, which to many people is a more desirable situation. Okay, well, I showed you that BTK inhibitors were better than chemotherapy. Now I'm going to prove to you that venetoclax plus obinutuzumab is also better than chemotherapy in CLL. And that's based on 3 different clinical trials. And again, there are many more, so these are just examples. But the CLL-14 trial was done in patients with previously untreated CLL who were a little bit older and maybe had some other medical illnesses and so on. And so they were not patients that were suitable to get FCR chemotherapy at the time because FCR would have been too toxic. So their chemotherapy would have been chlorambucil plus obinutuzumab. So this was a randomized trial of venetoclax plus obinutuzumab versus chlorambucil plus obinutuzumab. And what you see here is that at 4 years, the progression-free survival was 74% compared to only 35%. Now, I told you that minimal residual disease with BTK inhibitors is close to zero, but interestingly, with venetoclax and obinutuzumab, the number of patients with undetectable disease was 76%, which is amazing. If you look at side effects, there were similar rates of side effects, perhaps a little bit more neutropenia with the combination venetoclax obinutuzumab. So Veno clearly a winner over chlorambucil O in older patients or patients with other medical illnesses. What about in young patients? So in fit patients with CLL who have not previously been treated, who don't have a TP53 mutation, which I can talk about later. This was a randomized study of venetoclax obinutuzumab versus standard chemotherapy, which was either FCR or BR. Again, 5-year progression-free survival was 70% with venetoclax obinutuzumab versus 50%. So a 20% improvement in progression-free survival at 5 years. Again, undetectable MRD was 60% with Veno. In this case with FCR, remember I showed you before that when FCR was compared to ibrutinib, there was about a 60% undetectable minimal residual disease with FCR. In this case, because some patients had BR, which is not as strong as FCR, overall it was 22% with the chemotherapy. And there were fewer hematologic toxicities. That means low blood counts. So fewer patients getting Veno had anemia, thrombocytopenia, or neutropenia compared to patients getting chemotherapy. And then finally, a very interesting study called the Amplify trial. This was a three-arm study which looked at acalabrutinib plus venetoclax, acalabrutinib plus venetoclax plus obinutuzumab, or chemoimmunotherapy. And what this trial showed, and I'll show it later, is that progression-free survival with the venetoclax-based treatments was better than with chemotherapy. So this is a study combining the BTK inhibitor with the BCL2 inhibitor. And interestingly, it was very well tolerated. So even when you added the two treatments together, the toxicity was not so bad that you wouldn't consider that to be a better treatment than chemotherapy. So that was venetoclax plus acalabrutinib, but venetoclax plus ibrutinib has also been studied. And both of these regimens now have been tested against chemotherapy in first-line CLL, and both are better. There's very high response rates, high rates of undetectable minimal residual disease. Both of them are time-limited therapy. So now you can give your BTK inhibitor as a time-limited therapy when you combine it with a BCL2 inhibitor. And again, not a lot of increased toxicity compared to either agent alone. So this is I'll be honest with you, this is a slide that AI put together for me that just puts the response rates and the progression-free survival and so on together on one slide, looking at two different studies. But in one study, you had venetoclax ibrutinib in blue. In another study, you had venetoclax acalabrutinib in orange. And then the two studies had chemotherapy, so that those patients are all combined together in the chemotherapy. So the overall response rate with the combination Ven-I or Ven-A was 93-94% compared to 78% with chemotherapy. The complete response rate turned out to be higher with the Ven-I at 45%, 35% with Ven-A. You can't use this to say that Ven-I is better than Ven-A because they were different populations of patients. But with chemotherapy was only 28%. Rates of MRD negativity, 65% essentially with the combinations, 25% with the chemotherapy, and the rates of progression-free survival at 3 years were 90% with the combinations and only 70% with chemotherapy. Sorry, that's at 5 years. So you can see, I think we can make the case that the combination BTK inhibitor plus BCL2 inhibitor is now the new standard of care for first-line CLL. So the third group of targeted therapies I'm going to talk about are bispecific T-cell engagers, or BiTEs, so also referred to as bispecific antibodies. So you'll hear all three of those terms talking about the same thing. Now, these are antibodies. They're bispecific antibodies, so they have two arms. They have one arm that attaches to a CD3 receptor on a normal T cell, and they have another arm that attaches to a CD20 receptor on a malignant B cell. And what happens now is that you've got this antibody that pulls the T cell very close to the malignant cell. And when you get that T cell that close to the malignant cell, it activates the T cell. And when it activates the T cell, what happens is that inflammatory cytokines are released. So these are molecules that are involved in inflammation. And essentially that T cell then gobbles up and kills that malignant B cell. So under normal circumstances, your T cells are circulating around, your malignant cells are circulating around, but they can't get close to one another. So your T cells aren't able to act on the malignant cells. So the bispecific antibody pulls them together. This is really exactly the same way that CAR T therapy works, except in CAR T therapy, instead of using a bispecific antibody to bridge two cells, in CAR T therapy, you're inserting an antibody into the normal T cell, and that antibody inserted in the T cell has the receptor for the B cell. But the concept is the same. It brings the T cell up close and personal with the B cell and allows the T cell to do its job. So CAR T, I've talked about it, and many of you will know about it because it's a huge therapy in refractory diffuse large B-cell lymphoma. So in aggressive lymphomas, previously, if you weren't cured with the second-line stem cell transplant, then treatments work very poorly. But then CAR T came along and probably is curing maybe 50% of those patients where nothing else used to work. The problem with CAR T, though, is that it can only be done at certain specialized centers. And right now, most provinces in Canada have a single center. There are some provinces that don't have a CAR T center yet. And Ontario, I think, has 3 active CAR T centers. So it's not available everywhere that you live in Canada. And for a lot of people to get CAR T, it means a lot of travel. It means being at the specialized center for at least a month and having a caregiver accompany you to the specialized center and stay that length of time. The other problem is that in aggressive relapse of diffuse large B-cell lymphoma, sometimes the disease is growing very quickly and you don't have a lot of time, but the process of making the CAR T takes at least 3 to 4 weeks. So you need to be able to have the patient get through that 3 to 4 weeks to actually get the treatment. Whereas bispecific products, they're a manufactured product. They don't require any of this 3 to 4 week production time. They're off the shelf. They're like a targeted drug. And they're safer than CAR T, so they can be used in many more locations. So the goal of that is to deliver this kind of therapy closer to home. Right now, we have epcoritamab and glofitamab that are both approved and funded in Canada. Epcoritamab is a bispecific therapy that's subcutaneous. When you start epcoritamab, it's an indefinite treatment, so you use it until progression. Glofitamab is an intravenous version. It's a fixed duration therapy, so it turns out to be about 9 months of therapy in total. And when you use glofitamab, you get an extra dose of a monoclonal antibody 1 week before starting. Both of these medications, epcoritamab and glofitamab, have what we call a ramp-up dosing schedule. And that ramp-up dosing schedule is because we know that if we start right away with the full dose, it can cause too much toxicity. You have to gently ease it into the system by giving a very small dose and then a medium dose 1 week later, and then the full dose in the 3rd week. And unfortunately, though, that means being at the bispecific therapy site once a week for 3 weeks. And again, like CAR T, right now, there are specialized centers that are giving bispecifics, not available everywhere, although the goal is to make it available everywhere. So I've already said this, but when patients with diffuse large B-cell lymphoma, if they relapse after they've had 2 prior treatments, and in younger patients, the second treatment would be a stem cell transplant, then if you look at how they do with chemotherapy options that are available for 3rd-line treatment, unfortunately, the response rates have been less than 30%, and most responses don't last more than 6 months. So progression-free survival less than 6 months. In fact, most patients survive less than 1 year in the absence of CAR T and bispecifics. But now if you look at how the bispecifics have done, for both the medications, the overall response rate is up to 60%. The complete response rate, which would be 0 with chemotherapy, is at 40%. And for the patients who did achieve a complete remission, most of those patients will stay in remission for 2 years. So really incredible results compared to what was previously available. So good, in fact, that we're now saying, well, if these medications work so well in patients for whom nothing else has worked, what if we add them to chemotherapy either in 2nd line or even in 1st line and improve our cure rate with the 1st line so that patients don't have to have a 2nd or a 3rd line of therapy? So there's now a number of clinical trials that have done that. So in 1st line, we have glofitamab combined with Pola-R-CHP. That's a phase 3 study with over 1,000 patients. It's called the SkyGlow study, and we're waiting to see the results of that. Epcoritamab has been combined with R-CHOP. That's in phase 1 and phase 2, smaller number of patients, but in that small number of patients, the overall response rate was 100%, and the complete response rate was 73%. So these numbers, I can tell you, are better than what we would expect with R-CHOP alone. Now, if you look at second-line therapy, you've got a clinical trial of glofitamab combined with GemOx, so that's gemcitabine and oxaliplatin. So it's Glofit plus GemOx versus GemOx alone, and GemOx could be considered a standard kind of chemotherapy that we would use that we know has a response rate of only 30% and a very short survival. This was a phase 3 study with 274 patients. The CR rate with the Glofit GemOx was 50%. This hazard ratio for overall survival, what this is saying is that there was a 38% reduction in deaths due to lymphoma in patients that got the combination of Glofit plus GemOx versus those that got GemOx alone. And then finally, there's a study of epcoritamab combined with GemOx. This is an earlier phase study, a phase 1 and 2 study with 103 patients, overall response rate 85%, complete response rate 61%. So definitely the future holds combination of bispecific antibody targeted therapies with chemoimmunotherapy in first-line treatment of these aggressive lymphomas. This is a graphical representation of the STARGLO study. So this Glofit GemOx versus rituximab GemOx. And here you can see overall survival. So the top curve is patients that got Glofit plus GemOx. This median overall survival is saying that with an average follow-up of 20 months, less than 50% of people had died. But if you look at the standard chemotherapy R-GemOx, the median overall survival is 9 months. So 50% of people had passed away when we reached the 9-month mark. So incredible improvement in overall survival. And if you look at the 24-month mark, we're talking about 52% versus 33%. Okay, so in this final section, I want to make the case that chemo-free is not toxicity-free. And in the last 5 years of my practice, I've had so many patients say to me when we were talking about their lymphoma or their CLL and now they needed treatment, they'd say to me, I want a chemo-free regimen. And I'd say, well, what do you mean? And they'd say, well, I don't want side effects. And the truth is that if we had a regimen that worked extremely well and had 0 side effects, that would be the holy grail, if I can say that. That would be the gold medal of any kind of therapy. But no therapy is toxicity free. So even these chemo-free regimens, even these targeted therapies do have side effects. And why is that? Well, I talked about BTK and BCL2 being overexpressed within certain cancers, but they are still present in normal cells. And because they're in normal cells, those targeted therapies will still affect the normal cells. It'll be less so than the cancer cells, but the guided missiles are not perfect. And so inhibiting the pathways in normal cells will have effects. And a perfect example, so the BTK inhibitor ibrutinib, when it first came along, one of the main side effects of ibrutinib was that it caused bleeding and bruising. And the reason for that is because BTK is an important protein in platelets. Platelets are the blood cells that are responsible for clotting your blood. So if you're inhibiting your platelets with the BTK inhibitor ibrutinib, the consequence of that is going to be bleeding and bruising. So, somebody who, if you could ever find somebody that says, I want to debate and say chemotherapy is better, that person would say, well, see, even your targeted therapies have off-target effects, right? So they have side effects. The bottom line, though, is that in randomized studies where you compare targeted therapies to chemotherapy, the targeted therapies both did better and had fewer side effects. Similarly, the bispecifics in the lymphoma, so they bring that normal T cell into contact with the lymphoma cell, and I show the picture of that, and that activates the immune system, and the immune system releases the cytokines. But the problem is that immune system process can grow out of control. So something called the cytokine release syndrome or cytokine storm can happen. And that's an important possible toxicity of the bispecific antibodies. So here I'm showing this targeted therapy guided missile metaphor again, but here now you can see, so yeah, most of the guided missiles are attacking the cancer cells, but there are smaller effects on the normal cells as well. And if you kind of think of this one, well, this one is attacking the cancer cell, but the explosion that happens is also affecting innocent bystanders. So that would be sort of the cytokine release situation with bispecific therapy. So if you look at the typical toxicities of BTK inhibitors, we have bleeding, which I just talked about. We have atrial fibrillation, which became a very important side effect of ibrutinib. And in fact, the reason that acalabrutinib and zanubrutinib were developed was because they were designed to have similar BTK effect on the cancer cell, but less BTK effect on the platelets. And in fact, they were less effective on the platelets. And so acalabrutinib and zanubrutinib, less effect on atrial fibrillation, less effect on bleeding. So nowadays, those are the choices, and we don't prescribe ibrutinib very often anymore. Hypertension is another cardiovascular side effect of BTK inhibitors. And then these next three, I refer to these as, well, the next two, diarrhea and arthralgia or joint pains. Those are sort of the nuisance side effects that can happen. They happen randomly. So somebody can be, fine on their acalabrutinib for a year, and then suddenly they develop diarrhea. It goes on for 3 or 4 weeks, and then it goes away. Well, that was not an infection. That was an effect of the BTK inhibitor. Joint pains, in fact, are such a nuisance that joint pains actually lead to reductions in the doses of BTK inhibitors in a lot of patients that are having good effect from them. And finally, even though BTK inhibitors are not chemotherapy, they do suppress the immune system, and therefore there are infections that occur in patients on BTK inhibitors. Now, if we look at the toxicity of BCL2 inhibitors, like venetoclax, so the first one I'm going to talk about is tumor lysis syndrome. So what is that? So if you take a patient with a lot of CLL, so they have millions of cancer cells that are present, and you start them on venetoclax, if it worked perfectly, if your one dose of venetoclax killed every cancer cell, then all those cells would break open and they would release their contents into the bloodstream. And those contents include things like potassium and calcium and phosphate. And the buildup of those electrolytes can cause serious problems with the kidneys and with other organs. So that's referred to as tumor lysis syndrome. Now, we've never seen tumor lysis syndrome in CLL before. I mean, we've seen it, but it's extremely rare. But when we first developed venetoclax in the first patients, before we knew just how effective it was, we saw tumor lysis syndrome. And you can imagine the investigator that first saw tumor lysis syndrome with venetoclax, even though it was a devastating effect for that individual patient, it was a eureka moment for just how effective venetoclax works. And when I talked about venetoclax resulting in undetectable minimal residual disease, that again goes to show you just how potent this medication is. So tumor lysis syndrome is a big deal with venetoclax, and there's lots that we have to do to try to avoid it. Neutropenia can be a problem with venetoclax, and sometimes we need to give Grastafil, which boosts the production of neutrophils to make up for that, because again, we want to keep our venetoclax obinutuzumab patients on treatment for a full year. And so we don't want them to have infections, so sometimes we have to give Grastafil. Venetoclax can also cause nausea, diarrhea, or constipation, and it also suppresses the immune system, so there's an increased risk of infections with venetoclax. So even though that's the case, if I go back to my AI creating a chart of the toxicities of the combinations BTK inhibitor plus BCL2 compared to chemoimmunotherapy, you can see, well, if you look at infections with venetoclax and ibrutinib, your infectious rate is about 15%. With venetoclax and acalabrutinib, it's about 12%, but with chemotherapy, it was 20%. So still more infections with chemotherapy. If you look at cardiac events, 10% with venetoclax ibrutinib, 6% with venetoclax acalabrutinib, 5% with chemotherapy. So again, this 6% versus 5% is sort of showing the point that the acalabrutinib has less cardiac toxicity than the ibrutinib, which is what it was designed to do. If you look at neutropenia, 25% with venetoclax ibrutinib, 20% venetoclax acalabrutinib, 35% with chemotherapy. And then most importantly, if you look at any kind of side effect that led to death, so a treatment-related mortality, that was 2% with Ven-I, 1% with Ven-A, and 5% with chemotherapy. So yes, despite the fact that there are toxicities of these medications, even when you combine them together, they do better than chemotherapy in terms of their side effects. So choosing between a BTK inhibitor or a BCL2 inhibitor in first-line CLL, this could be a discussion we could spend half an hour on, so I'm not going to get too far into it. But again, the things that we think about with the BTK inhibitors, they're intended to be continuous treatment, whereas with BCL2 inhibitors, they're intended to be fixed duration. So some people would say, you know what, I'd rather have 1 year of therapy and then be treatment free rather than start a drug now and maybe have to be on it for 10 years. So that would be one sort of factor that might move you towards BCL2 inhibitor. Secondly, convenient dosing. So BTK inhibitors, it's the same dose every day. I can prescribe it, a patient can go home and take it, and I don't have to see them for a month or 2 months or 3 months. They just take the same dose every day. Whereas with BCL2 inhibitors like venetoclax, we have this risk of tumor lysis syndrome. So at the beginning, we actually have to monitor them very closely with this ramp-up dosing. And so that requires either admitting patients to the hospital for several days or even weeks, or having them come to the clinic 3 days in a row every week for the first 4 weeks. So really, that's very inconvenient, especially for patients who live far away from the hospital. So the dosing convenience may be a point in favor of the BTK inhibitors. The cardiac risks, definitely a point against the BTK inhibitors. With the BCL2 inhibitors, because they're both combined with a monoclonal antibody, either rituximab or obinutuzumab, there are visits to the chemotherapy unit for those infusions. And then a final point in favor of BTK inhibitors is that in patients with the highest risk CLL, those that have either a 17p deletion or a mutation of TP53, the BTK inhibitors actually work better than the BCL2 inhibitors. So lots goes into that decision. What about the toxicity profile of bispecific antibodies? Well, I talked about cytokine release syndrome already. There's a specific neurotoxicity that happens with bispecific antibodies. It's called ICANS. Now, the rate of ICANS is very low, less than 5% with both epcoritamab and glofitamab, whereas with CAR T, the rate of ICANS is fairly higher than that. So it's less of an issue, but it is still an issue. The bispecific antibodies do deplete the immune system, so there's still a risk of infections. Patients on the bispecific antibodies can complain of fatigue, and there are low blood counts, and sometimes transfusions are needed. So to summarize what I've talked about so far then, so why do targeted therapies matter in lymphoma and CLL? Well, there is a shift from chemoimmunotherapy to targeted agents, and so we are moving towards a chemo-free era. There are better outcomes and fewer toxicities, so it's win-win. And there can be personalized treatments based on genetics. So for example, in patients with CLL with a 17p deletion, you might choose a BTK inhibitor. But patients who don't have a 17p deletion, you might choose a venetoclax-based therapy. Or in patients with activated B-cell diffuse large B-cell lymphoma, it would make sense to combine a BTK inhibitor with chemotherapy, but maybe less sense to combine a BTK inhibitor with chemotherapy in patients with germinal center B-cell diffuse large B-cell lymphoma. So we're moving towards chemo-free and personalized treatments. Future considerations, as we better understand the biology, we identify new targets. So every meeting, there's 2 major meetings in hematology every year. There's the European Hematology Association and the American Society of Clinical Oncology meetings. Those happen in June. And then there's the American Hematology Association meeting in December. So every 6 months we get updates, and every 6 months we're learning about new proteins to target within cancer cells and new medications that do target those proteins. And here I've just listed a tiny fraction of them. We are moving towards a chemo-free era. I've already said this. Chemo-free treatment will be less toxic, it'll be more effective, and it'll be tailored to an individual cancer. So with that, I thank you for your attention, and I think that we have some time for questions.
Thank you, Dr. McDonald, for breaking down the term targeted therapies. We will take a few questions. So can you speak to treatment for CLL recurrence where I have a 17p deletion and trisomy 12 and allergy to rituximab?
So obviously, treatment options are more challenging in patients with relapsed disease. So it's very straightforward to talk about a BTK inhibitor as being the best frontline therapy for somebody with a 17p deletion. The trisomy 12 is less important, and the rituximab allergy, we can come back to that because it can be dealt with. But right now, the standard sequence of therapies is to give a BTK inhibitor first for as long as it works, and then to give a venetoclax-based therapy as the second line. And usually when we're giving venetoclax in second line, we're giving it in combination with rituximab, but it can actually be given by itself. So that would be one option, would be venetoclax by itself. And then, another option would be to look at why did you progress after your BTK inhibitor? And it may be that you have a binding site mutation. We can't test for that, but certainly pirtobrutinib could be considered as a treatment option if you and your hematologist can navigate the complicated way of importing that into Canada. You could look for a clinical trial of nemtabrutinib, and there are a number of centers. I have a nemtabrutinib on trial. Unfortunately, for the relapsed patients, it's a very specific population. So if you haven't had venetoclax before, then you wouldn't yet be eligible for the nemtabrutinib trial. And then, bispecifics are not yet approved in CLL, but of course they're developing in lymphomas, and they will become available in CLL. There are newer medications that are becoming available, like BTK degraders, and those work in patients who have become resistant to BTK inhibitors. So, I think right now, in terms of standard options, it would be a venetoclax option. In terms of managing the rituximab allergy, I think that there are sensitization procedures that can be tried with that. But venetoclax can be given by itself. And it wouldn't be outlandish to think maybe giving venetoclax, but adding back in the BTK inhibitor, if you can boost its effect by adding the venetoclax, maybe it'll still provide some benefit.
Okay. And if CAR T fails, are BiTEs available afterwards as a treatment option?
Yeah, so right now, BiTEs, epcoritamab and glofitamab in Canada, are available as third-line treatment. And that can be either after failure of CAR T, if CAR T was given in second line, or it can be after any two prior therapies that don't have to include either stem cell transplant or CAR T. So yes, for CAR T failures with diffuse large B-cell lymphoma, bispecifics are now available and funded. And they're also available, by the way, in third-line follicular lymphoma. So epcoritamab is available in that as well.
Okay. And there's a question similar to that. Are those therapies covered by provincial healthcare systems?
So yes, and as you all know, one of the problems in Canada, it's a great system in Canada compared to the American system, I still believe, but one of the challenges is that all of the provinces make individual decisions about what treatments they're going to fund, and so sometimes the criteria aren't exactly the same from one province to the next. But I can say that across the board, venetoclax is approved everywhere in Canada and reimbursed, so it's funded. Ibrutinib, acalabrutinib, and zanubrutinib are funded every province in Canada. Bispecific antibodies are funded, I believe, in every province in Canada. If there is a province that they're not funded in yet, that will very soon happen. And similarly, CAR T funded in every province in Canada.
Thank you, Dr. McDonald. Were you going to comment something else, or? No, okay, perfect. I do see some comments that are related to specific subtypes, but in the sake of time, I'm going to end it here. We do have subtype sessions that are happening tomorrow, featuring various different subtypes, including Hodgkin's, mantle cell lymphoma, diffuse large B-cell Waldenstrom's. I recommend that you go and see the agenda for day 2, so you know which sessions you want to attend tomorrow. And thank you, Dr. McDonald, again, for taking the time to prepare this presentation. I know we're getting late into the night and we went a little bit over time, but of course we wanted to make sure that we had some time to answer the questions. And with that, I just want to direct the audience to attend the closing remarks for the day. Thank you for all the engagement throughout the day, and I look forward to hosting the sessions tomorrow. Thank you, everyone. See you tomorrow.
Thank you, everyone.